Welcome to Pathology Central Key Concepts. The topic of this video is pathophysiology of lung tumors. In this video, I will compare and contrast the different types of carcinomas of the lung, as well as their associated paraneoplastic syndromes. Now, there are a variety of different ways that we can classify lung cancer. When I was a medical student and resident, we typically would consider the different histologic types as two primary categories: small cell carcinoma and non-small cell carcinoma. The reason for this approach is based on therapeutics. Small cell carcinoma is an aggressive, rapidly growing malignancy that is often metastatic at diagnosis and therefore is not amenable to surgical resection and requires systemic chemotherapy. However, the non-small cell carcinomas, so adenocarcinoma and squamous cell carcinoma, didn't have particularly good chemotherapeutic regimens we could use. But on the plus side, they tended to grow more slowly than small cell carcinoma, so surgery was often an option. In the intervening decades, since I was a medical student, we've continued to learn more about the pathophysiology of these diseases and have developed some targeted therapies that we can use for our non-small cell carcinomas. So we'll talk about those more in a bit. So that's one way to look at it, just small cell, non-small cell. Here is a simplified table from the World Health Organization, just to give you an idea of the spectrum of malignancies we can see in the lung. What we'll be focusing on in Robbins will be adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. If you understand these three, you'll be in good shape for taking care of patients. Large cell carcinoma is a diagnosis of exclusion. And then we have this other category, which is going to include some unusual morphologic variants. Before I move on, I would like to just point out that we can get mixed carcinomas, such as an adenosquamous carcinoma or a small cell carcinoma with something else. But for the rest of this video, we're going to focus primarily on these three entities. Now, we can't talk about lung cancer without talking about cigarette smoking. There's a very strong association between smoking and small cell carcinoma and squamous cell carcinoma. These tumors arise in the hilum of the lung. This is the area which, if you think about it, is going to get the brunt of that inhaled bolus of carcinogens and toxins and mutagens with the inhalation of cigarette smoke. There is a moderate association with adenocarcinoma. So about 90% of lung cancers will be diagnosed in patients who are currently smoking or who recently quit. But the flip side to this is that only about 11% of heavy smokers develop lung cancer. And this can be an issue when you're discussing smoking cessation, because a patient may say that I know lots of people who smoked for a long time and they never got lung cancer. Why should I worry about this? And that has to do with the individual's genetic background, polymorphisms as far as cytochrome P450, etc., as well as additional environmental toxins. Nonetheless, we know that this is dose dependent, that we have increasing risk with increasing pack years of cigarette smoking, with reduced risk with smoking cessation or reduction. However, we do not return to baseline. Now, one thing that may account for the difference in smoking incidence in various populations has to do with additional toxins. So, for example, we know that tobacco smoke will synergize with asbestos, so that non-smokers who are exposed to asbestos have about a 5-fold increase in their risk of lung cancer compared to a 50 to 55-fold increase in heavy smokers. But while we focus so much on the link between cigarette smoking and lung cancer, we cannot forget that 10 to 15% of lung cancers will arise in never smokers when we look at Western countries. These are typically going to be adenocarcinomas, often with targetable mutations for chemotherapy. But just to bring back some of the material from Chapter 7 of Robbins and Kumar Basic Pathology, Environmental Pathology, this shows you here the linear correlation between cigarettes smoked per day and relative risk of lung cancer. And this is just to remind you of some of what those carcinogens are and what these other toxins do in the lung. Now, before we go to the different types of lung cancer, I want to focus on the patient. So how will these patients present? So most lung cancers are going to present at a high stage. The typical patient will be someone with a smoking history in their 50s, and they'll have several months of symptoms that are somewhat nonspecific: a cough, chest pain, or weight loss. Something else that you can see often perhaps more on exams than in a patient population is something called Horner syndrome. This is when we have a lung tumor at the apex of the lung. These particular tumors in the apex are referred to as Pancoast tumors. It doesn't matter the histologic subtype. And they can invade into the cervical sympathetic plexus, resulting in a constellation of symptoms. So in enophthalmos, we're going to get a turning inward and sinking in of the eye. Ptosis will be a deviation of the eye on the side of this tumor. We also get miosis, so constriction of the pupil, and anhidrosis, so an area of decreased sweating. Again, all of these are going to be ipsilateral to that tumor. So we talked a little bit about the clinical presentation, so cough, hemoptysis, chest pain, but I don't want you to forget that there are a wide range of clinical features associated with local effects of lung tumor spread. This is a really fantastic table from Robbins and Kumar Pathologic Basis of Disease that I like because it explains the pathologic basis for these clinical features. So the cough will be due to involvement and obstruction of central airways that can lead to distal atelectasis and infection, leading to our cough. Hemoptysis can be from hemorrhage from that tumor eroding into a blood vessel. We can get chest pain because of the extension of the tumor into a variety of surrounding structures. Other things to keep in mind, we think about hoarseness and dysphagia as being associated with esophageal malignancies, but keep lung cancers in mind if you have a patient with these presenting symptoms. Superior vena cava syndrome, when we have a large tumor that compresses the superior vena cava, and I've already mentioned Horner syndrome. So with that in mind, let's go ahead and begin with our first entity, and that is squamous cell carcinoma. So as I've already mentioned, it has a strong association with cigarette smoking, and as a consequence, squamous cell carcinomas tend to have a high mutational burden. This is because we get this inhalation of these mutagens that are going to affect the bronchial epithelium. So we're not looking at a single point mutation or a translocation. We're looking at the sort of background that we'll see in cancers associated with ultraviolet radiation, so squamous cell carcinoma of the skin. Now, there are a variety of precursor lesions, so squamous dysplasia and carcinoma in situ that lead up to carcinoma, invasive carcinoma. But we also have a variety of morphologic changes that are associated with smoking. So this can begin fairly innocuously with some goblet cell hyperplasia, some basal cell hyperplasia, and then we can get squamous metaplasia. The bronchial epithelium is delicate and is not able to withstand the injury from the toxins in cigarette smoke, so it will undergo squamous metaplasia. And as you learned in Chapter 1 of Robbins and Kumar Basic Pathology, metaplasia is fertile soil for the development of dysplasia, and dysplasia can lead to carcinoma in situ and invasive carcinoma. Regarding the pathogenesis, we know that TP53 mutations are an early event because we see it in about 10 to 50% of squamous dysplasia, but we get increasing incidence with squamous cell carcinoma in situ and invasive carcinoma. We can also see mutations in the CDKN2A locus. This encodes the cyclin-dependent kinase inhibitor P16. Think back to the neoplasia chapter, the role of RB in the cell cycle, and how the cyclin-dependent kinase inhibitors will slow that progression. We see mutations in this locus in about 65% of tumors. So this is just two images to show you what we can see before we get to invasive carcinoma. This is not considered a precursor lesion. This is simple metaplasia in response to cigarette smoke. We have our bronchial epithelium here with its cilia that is being replaced by squamous metaplasia. This can then progress to dysplasia, which we can see here in this image from Robbins and Kumar Basic Pathology. Now, these dysplastic cells can be shed, so we can find them in bronchoalveolar lavage or sometimes in sputum specimens. So if you have a suspicion of a squamous cell carcinoma in a patient, you might do a bronchoalveolar lavage for a cytologist to take a look at. And you can see here we have this high NC ratio with this large hyperchromatic irregular nucleus and this pink keratinization in this shed squamous cell. So morphologically, as I've already mentioned, these are typically hilar or central tumors, but they can be peripheral. They can present either as an exophytic mass in the bronchial lumen, which can lead to obstruction with distal atelectasis and infection, or we can get a simple intraparenchymal mass that can compress a surrounding lung. On cut surface, the tumor is grayish-white and firm and can have areas of hemorrhage, necrosis, and cavitation. And I'll show you a histologic image that explains this cavitation. Microscopically, we can see the full range of differentiation from well-differentiated to poorly differentiated with varying degrees of keratinization. In well-differentiated squamous cell carcinomas, we may see well-formed intracellular bridges of the desmosomes between keratinocytes that are still holding together, as well as squamous pearls. The surrounding lung will often have adjacent squamous metaplasia, dysplasia, and carcinoma in situ. So here is an example of a squamous cell carcinoma that's invading here in the lung. You can see it's central. It's arising at the hilum of the lung and has this grayish-white appearance to it. Histologically, this is about the best example of a well-differentiated squamous cell carcinoma you can see. There's a keratin pearl here. And then we have our intracellular bridges here showing those desmosomes that are holding our keratinocytes together. So why do we get cavitation? This example of a moderately differentiated squamous cell carcinoma can provide a clue. Now remember that the role of squamous epithelium is to shed squamous cells into the surface. So the squames on your skin are shed into the environment. If you have squamous mucosa that cannot shed to a surface, those shed cells are going to form a central necrotic mass. As this lesion grows, that central necrotic mass can become even larger, and we can actually see this sometimes on imaging, a large cavity at the center of this tumor filled with necrotic debris. If we get erosion into a blood vessel, this can result in catastrophic hemorrhage. The next entity to consider is also strongly associated with smoking, in fact, even more so than squamous cell carcinoma. In small cell carcinoma, only 1% of cases occur in non-smokers. It has the highest mutational burden of the lung cancers. Again, this makes sense because of its strong tie to cigarette smoking. It's an extremely aggressive tumor, usually metastatic at diagnosis, and median survival is only about 10 months. In the pathogenesis, we tend to see almost universal inactivation of both RB and TP53. We can also get deletion of the short arm of chromosome 3, which has an undefined tumor suppressor gene there. Another finding will be MYC amplification. Remember, MYC is involved in changing cellular energetics and contributes to rapid growth. So morphologically, again, usually hilar/central, but it can be peripheral, tan white and soft with areas of necrosis. Remember, necrosis is a feature we associate with rapid growth as the tumor outgrows its vascular supply. Microscopically, it's composed of small, round, spindled cells with scant cytoplasm. It's sometimes been referred to as oat cell carcinoma because the spindled cells can look like grains of oats. There are ill-defined cell borders. The nuclei have fine chromatin with inconspicuous nucleoli. Mitotic activity is brisk, and there's necrosis. Now, on electron microscopy, we can see dense core neurosecretory granules. This is relevant because we consider this to be a neuroendocrine carcinoma, and this helps explain the paraneoplastic syndromes that we see with small cell carcinoma. Here you can see a medium power view of a small cell carcinoma showing quite clearly an area of necrosis due to this rapid growth. The cells here have an almost syncytial appearance with very minimal cytoplasm. Let's look on higher magnification here. And you can appreciate, I think, beautifully here this salt and pepper chromatin, this very fine chromatin, no nucleoli. Another feature here is nuclear molding. You can see that the nuclei seem to have molded around to fit each other. We don't see nucleoli, and in this particular example, I don't see brisk mitotic activity. Now, this is a neuroendocrine carcinoma, which means we have to take a brief detour into the carcinoid tumors. So carcinoid tumors are about 5% of pulmonary neoplasms. They're referred to as carcinoid because they were not carcinomas, but they are best reviewed as a low-grade neuroendocrine carcinoma. They tend to affect younger adults with a median age of 40, and most will originate in the main bronchi. They can present either as a polypoid spherical intraluminal mass, again causing distal atelectasis with obstruction, or it can be a plaque that penetrates the bronchial wall. We further will classify carcinoid tumors as being typical or atypical. So typical carcinoids have nests of very uniform cells with regular round nuclei, that fine salt and pepper chromatin, and absent or rare mitotic figures. In atypical carcinoids, we see an increased mitotic rate, perhaps small foci of necrosis, and there's an increased risk of lymph node and distant metastases. TP53 mutations are seen in about 20 to 40% of atypical carcinoids. Now, keeping this in mind, they both are usually resectable and curable. Here is an image showing a bronchial carcinoid, this polypoid lesion right here in the bronchus, and then the classic appearance of a typical carcinoid, not an atypical carcinoid, with these nests of very regular bland cells with round nuclei and fine chromatin, no mitotic activity. Now, the clinical features of carcinoids will depend to some extent on where they grow. So intraluminal masses can present with cough, hemoptysis, and recurrent pulmonary infections. Peripheral tumors are typically discovered incidentally. Now, about 10% of cases will have something called carcinoid syndrome, which we can also see in carcinoid tumors of the gut. This is characterized by intermittent diarrhea, cyanosis, and flushing due to mediators that are released by the tumor cells. Now, I mentioned that both typical and atypical carcinoids are typically curable. There is definitely a better survival for typical carcinoids with a 5 and 10-year survival rate of about 85%. With atypical carcinoids, the 5 and 10-year survival are 56 and 35% respectively. So finishing that detour, let's return to our last significant carcinoma of the lung, adenocarcinoma. So this is most common in never smokers, women, and patients under 45 years old. There is, however, a moderate association with cigarette smoking. Now, what we've learned about adenocarcinoma is that it typically has a variety of mutations that we can target using chemotherapy. So activating mutations of the epidermal growth factor receptor, EGFR, are seen in about 20% of cases. KRAS mutations are seen in about 30% of cases, and we can also see ALK rearrangements as well as mutations involving pro-growth pathways that involve RAS and PI3K. The upshot of all of this is that we can use targeted therapy for these tyrosine kinases, and this has been one modality which has improved survival in patients with adenocarcinoma. There are two precursor lesions that we associate with adenocarcinoma. These are atypical adenomatous hyperplasia and adenocarcinoma in situ. Probably this is best left to pulmonary pathologists and specialists to keep an eye on. Then just briefly to remind you of the pathogenesis, this is an image you've seen multiple times in these videos. Here you can see our epidermal growth factor receptor that typically will be stimulated by a growth factor to activate RAS, driving us down these pro-growth pathways. But if we have an activating mutation, we no longer need our growth factor. We have constitutive activation, which is going to drive us through these signaling pathways leading to cell growth. Morphologically, these are typically peripheral, and then histologically, we can see a variety of growth patterns, so the typical gland-forming or acinar appearance, or solid or papillary growth. They're typically slow-growing, small masses. So this gross image confirms that. This is a peripheral mass right here under the pleura, and it is quite small. This histologic image also shows that feature. Here it is right under the pleura. We have a little bit of residual unaffected lung here. And then here you can see these atypical malignant glands that are invading through the lung. On higher power, you can appreciate how atypical they are as well as their architectural features. This brings us to the last of the types of of carcinoma that we talk about in Robbins Basic Pathology. This is large cell carcinoma. As I mentioned, this is a diagnosis of exclusion, so we have to exclude, using immunohistochemistry, neuroendocrine squamous or glandular differentiation. And when we do that, we are left with large cell carcinoma. Now, This is a table from Robbins and Kumar Basic Pathology that I think is a useful overview and review as you study lung cancer. This divides it again into our small cell versus non-small cell, but further specifies here particular lesions associated with, for example, squamous cell carcinoma or adenocarcinoma. So this brings us now to the paraneoplastic syndromes. So about 3 to 10% of patients with lung cancer will develop a paraneoplastic syndrome. So in small cell carcinoma, which is our neuroendocrine carcinoma, it can make a variety of peptides as well as generate autoantibodies that result in paraneoplastic syndromes. So small cell carcinoma can release adrenocorticotropic hormone, resulting in Cushing syndrome. We can get release of antidiuretic hormone, resulting in the syndrome of inappropriate secretion of ADH. But another finding, which is quite unusual, is that we can get the formation of autoantibodies. This can lead to Lambert-Eaton syndrome, which we see in about 3% of patients with small cell carcinoma of the lung. In this, we get autoantibodies to the voltage-gated calcium channels, so this is going to cause weakness in patients. And then limbic encephalitis is due to autoantibodies that result in swelling in the limbic structures of the brain. Squamous cell carcinoma is most closely associated with hypercalcemia due to parathyroid hormone-related protein elaborated by the lesional cells. In adenocarcinoma, we tend to see coagulation abnormalities related to mucin release, so we can get migratory thrombophlebitis or Trousseau syndrome, non-bacterial thrombotic endocarditis, and disseminated intravascular coagulation. So how do patients with lung cancer do? I've already said that they typically present at high stage. That's going to be associated with a poor prognosis. In fact, the overall 5-year survival rate is only 18.7%. Now, with localized disease, the 5-year survival rate improves to 52%. And this is what we're going to see most commonly with our squamous cell and our adenocarcinomas because they tend to remain localized longer. Our treatment modalities will include surgery, chemotherapy, and radiation. We can also use specific kinase inhibitors as well as checkpoint inhibitors. Small cell carcinoma is sensitive to radiation therapy and chemotherapy. And while we can say that with limited disease, we have a 5-year survival rate of about 10%, almost all patients will present with higher stage disease. And so median survival is only 10 months. As usual, here are some questions for you to review the material we've just covered. I hope that this review of the different tumors of the lung has been useful. Please do subscribe. I would appreciate it. Thank you very much for your time and attention.